Good evening, everyone. So let's start today's Dental Vriksha session webinar. I would like to give a small introduction about our speaker today, Dr. Murugan sir. Dr. R. Murugan sir has done MDS, FIBOMS, and presently working as Associate Professor in Kadalur Government Dental College. And he has completed his BDS and MDS in Raja Mutaya Dental College, and he holds and has already been a part of IDA and holds different positions in various years. And Sir has given more than 30 and national and international publications and is running private practice for more than 23 years. Welcome, sir, and your experience will definitely help clinicians, and especially today's topic, tips and tricks in minor dental surgery. Thank you for accepting to be a speaker for today's session, sir. We welcome you on behalf of Dental Vriksha, and we welcome all the participants for today's session. Sir, we start the session if you're ready.
Thank you. Thank you for the introduction, Ma, and thanks for the invite for making me to present in front of you all. And today I'm going to, my screen is visible there?
Yes, sir, you can share the screen, sir.
Yeah, I have shared one already.
Yes, it is visible, sir.
Okay.
We can see you, the PPT is yet to come.
Yeah, so I'll open the PPT.
It's now seen, sir.
Yes. Tips and tricks in oral minor procedure. வருமா என்னன்னு click பண்ணி வச்சா வருது.
It is seen now, sir. You can continue. You can start.
Good evening, one and all. Now I'm going to discuss on tips and tricks in minor dental surgeries. What is minor dental surgery? First of all,
link
for little clarity, I want to explain about what is minor surgery first. When to do this minor surgery.
We request all the participants to please put your phone on mute so that there will be no disturbance in between. Thank you. Yes, sir, we can continue.
Yeah. What is minor dental surgery? Actually, we should divide minor surgery and major surgery. How to classify a minor dental surgery and how to classify a major dental surgery? First of all, we should know the line in between these two. All major surgical procedures should not be carried out in minor surgery way, and all minor surgical procedures should not be carried out in a major surgical way. So we should delineate a line in between these two surgical procedures. So when to say it as a minor dental surgery? The surgical procedure that can be comfortably done by competent dental surgeon within 30 minutes under local anesthesia with or without sedation. A procedure that can be done within 30 minutes is said to be called as minor dental surgery. Not in the sense I am saying more than 30 minutes is not at all a minor surgery. It will rely on the patient's systemic conditions. It will rely on the patient's procedure, how much blood loss is there, what is the anxiety level of the patient. All together will say whether it is a minor surgery or a major surgery. And in plan accordingly, procedures done which can be done within 30 minutes of time period is said to be a minor surgery, and we can do that under LA. More than that, we can opt for some other anesthetic methods. The common surgical procedures we used to do in minor surgery is transcellular extractions, as we all know, little impactions, cyst and benign tumors, prosthetic surgeries, periapical surgeries, and biopsies. All these are most commonly performed dental procedures in a dental setup, in a normal dental setup without any consultant help also. As I say, all these procedures can be done by a general dentist also. So it is there in the DCA curriculum also, and they are competent enough to do the surgicals. So I don't know who is Benjamin Franklin, but I like the quote, by failing to prepare, you are preparing to fail. This was a nice quote which suits to us. By failing to prepare means if you prepare the patient in a nice manner, the success rate will be more. If you didn't prepare, haphazardly, if you are taking up the patient for a minor surgical procedure, it will go and end up with a miss or some failures do occur. So, to gain a good success in surgical procedures, some basic principles should be followed. Coming to the basic principles, I am going to elaborate on each and every topics under these headings only. Basic principles of surgery rely on preoperative, intraoperative, and postoperative. I am not boring you people, I think so, because more of theory will be there and little bit clinical pictures I'll show later. So pre-operative is nothing but a good diagnosis paves a better way for treatment plan. What I am saying is, if you do a better diagnosis in the beginning itself, your treatment plan will be good. If you did go for a good diagnosis, sure you will end up in some lot of failures there. So diagnosis and treatment plan is very important before doing in the minor surgery. And after once the diagnosis and treatment plan has been set up, the patient's preparation is very important. Once the patient is prepared for surgery, preparation of patients is nothing but preparing the patient's health status, whether they have taken medications, pre-medications, diabetic medications, whether they have taken food or not, and all other things includes in the preparation. And that too, patients, whether they are paid or not, that too will be there in the preparation. And once all these preparations got over, basic armamentarium is very, very, very important. After keeping up the case here and moving around for instruments, we sure the patient's anxiety level will be increased, and also some amount of trustiness will get lost from the patient. So always keep instruments ready and then start doing the procedure. Pre-operative is very important. And coming to intraoperative, during intraoperative, any minor surgical procedure, adequate access is very important. To gain access, I'll show you how to gain access and all. And proper light is very, very important for the minor surgical field. And the surgical field should be free of blood and fluid. And more than that, pain management. Whenever we are doing any minor surgical procedure, pain should not be there for the patient. If at all pain is not there, there is no mess at all. So pain management is very, very, very important. And flap designing, tissue handling is very important. Soft tissue should be carefully handled. Hemostasis should be achieved. And once the hemostasis is achieved, then we have to go for suture. Why I emphasize these two, I'll explain in the coming slides. And post-operative care. What is the post-operative instructions I'm going to do? Little bit, 2 minutes before. Today morning, I operated a case under GA. The patient called me. I'm having a little bit bloating in the thing. I didn't give him PAN 40 injections for him. So now I had an injection. So all these things should be expected post-operatively. So you should explain everything to the patient. So the basic principles for a successful surgery relies on pre-operative care, intraoperative care, and post-operative care. And coming to diagnosis, as I said earlier, I am going to elaborate on all the headings which I said in the previous slide. Coming to the diagnosis depends on 3 major things: clinical examination, radiographic examination, and based on the biochemical investigations. Some diseases, on seeing clinically itself, we can identify, and this is a clear-cut case, we have to do this thing, and our plan is like this, and we are going to operate, so we can come to a conclusion. Some cases, additional information should be needed, so we will opt for radiographic examination. And nowadays, a lot of radiographic examinations, radiographic newer CBCT, everything is there, guidelines is there, easy diagnosis is possible. And then coming to biochemical investigation, certain diseases will have some amount of biochemical backgrounds. For example, some amount of osteolytic cysts and tumors will have some alkaline phosphatase level. Like that, some biochemical alterations will be there. All these should be kept in mind, and all these 3 things will pave way for a better. Am I audible, ma'am?
Yes, doctor. You're audible, doctor. No problem.
Thank you.
And other participants, please mute your screen.
Yeah, and coming to the clinical examination, what are the things you should see before the clinical examination? It's quite important actually. Whatever dental procedures we are doing, even a prosthetic procedure or any other procedure we are doing, we are going to do a reversible. Something happened to a denture, we can reverse it. But surgical thing is the only area where some mistake, it is a irreversible mistake to the patient. So always think in mind that surgery is an irreversible trauma to the patient. So we can't able to revert back to the normal condition. So to be prior to procedure, head to toe examination is important for the surgical thing. Why head to toe is important? Because head to toe will give you plenty of values regarding the systemic status of the patient. Just on seeing the color of sclera, we can say whether the patient is healthy or not, whether jaundice is there or not. Whether the patient is anemic or not, it can be well by lower conjunctival palpebra and nails clubbing or any gangrene formation will say peripheral blood flow to the nails, and facial edemas, particularly facial edemas in case of renal issues, in case of cardiac issues, it will be seen, and skin complexion. AV fistulas, hidden AV fistulas can be placed in case of renal failure patient, and breathlessness at rest and exertion. All these things should be examined. This is what to say head to toe examination. Lymphedema in the leg, all these will give you a details about the systemic conditions of the patient. Why I am saying this is, in our population, a lot of patients, whenever they are reporting to us, they won't clearly tell us what disease is there. Once after doing extraction, they will come to know this and that, I am having this, that. On the way of extraction, on the way of surgery, I have handled a lot of cases. In the middle of the procedure, they used to say me that I am having transplant, I have done this, that. So they won't give you a proper way. So better, we should examine them priorly before starting our procedure. So pre-operatively, this clinical examination is very, very, very important. And coming to our intraoral part. So on seeing a head-to-toe examination, if at all the patient is clear and healthy, we can take up the patient for procedure. And after take up the patient for procedure, see intraorally what type of gag reflex. Some patients will have gag reflex. On keeping the mouth movement itself, they will vomit. Those patients should not be taken up directly for minor oral surgery because we can't able to leave the patient after placing incision, or on the way or off the way, we can't able to relieve the patient. So in those conditions, we have to see whether gag reflex is there. If at all is there, anti-emetic drugs can be given pre-operatively and then we can take. There is no harm in it. Anti-emetic won't play any vital roles. It won't interfere with our surgical procedure at all. Then tongue position. Lot of macroglassic tongue patients will be there during, particularly in impactions. Whenever we are using rotary instruments, we should be careful. We should not cut the tongue. So tongue position is primarily important. Ask the patient, inform them that you are not supposed to move the tongue priorly before the surgical procedure. And cheek laxity. Assessment of case relies on this cheek laxity. Why? Because always third molar is, even it is too deeply impacted, if the patient is thin, it is easy for us to access and we can remove it. Even if it is superficial, if the patient is bulky like me, then it is very difficult to retract the cheek. So the cheek laxity plays a vital role in intraoral examination. So accordingly, you can plan and you can say the patient that the cheek is so thick, so I have to retract it. So you try to close it. So I'm going to cut the bone like that. You can explain it clearly and you can do some retractors also. You can have it and you can do retractions. And aspiration. Always, whatever foreign instruments or anything we are using, don't make the patient too lie down because aspiration rate will be more. So maximum do it in a semi-supine position or in an upright position. That is more than enough. So we are not supposed to recline for our access purpose. Some of us will keep the patient in most reclined position. That too for upper tooth extraction. For gaining access, we will keep them in there. A lot of times it happened for me also. While exiting the tooth root, it fall down and they have swallowed the root. Then I had to explain them, nothing will happen, it will come out. So then we have to do all these things. So aspiration is quite commonly happening, complications with minor surgical procedures. So aspiration you should avoid it. And cortical expansion. See, I have handled a case without X-ray. I used to do impaction in the beginning days. So what happened? One of my patients, after doing extraction, the tooth softly came out. Then I came to know something hidden things is there. Then I kept my hand over there. The cortical was so fluctuant. Then I go on curating it. It was like a cystic content inside, and the entire cyst has, entire ramus was involved, and they curated it. But anyway, I sent the patient for post-operative investigation. They are having a cyst in the thing. So any expansion in the cortex or any fluctuancy or any different changes is there, you have to opt for radiographic examination. Then only you have to support for clinical. Then only we can proceed for our minor surgical procedure. I am not in the sense saying that we are not supposed to take up the case if at all cortical expansion is there. If at all cortical expansion is there, we can take up the case Possibly, we have to go for radiologic investigation. We have to confirm once, then we have to take up the questions. All these are simple clinical tips. So kindly, is it okay for you, or I'll rush it up? I'll rush it up. So these are some of the, yes, sir. These are all some of the eye signs. You can see the sclera color clearly says the patient is having some jaundice or some hepatitis or some liver-related issues might be there, or some blood dyscrasis will be there. If at all liver diseases is there, it is followed by blood dyscrasis. So to see the lower conjunctival palpebra, whether the patient is anemic or not. Pitting edema in the leg says some left ventricular failure or cardiac issues or some renal failures. Everything will be associated with this pitting edema in the leg. And this clubbing type of nail, particularly in the congenital cardiac diseases patient, you can see this clubbing type of nail. Coming to the vital signs. What are the basic vital signs we should in a dental procedure? Before COVID, we didn't see anything. But after COVID, each and every patient is a victim for us. Why? Because we doesn't know what type of changes they are having, what type of clotting mechanism they are having. We doesn't know anything. So we are actually, as a dentist, I used to say me that we are the least person to write any investigations. I don't know why we are hesitating to write prescriptions. Investigation. Because coming to a general medicine people, they will write left and right prescriptions for each and every disease. They know how to write this and that, all type of investigations. Then only they can arrive at a diagnosis. I'm not criticizing them. I'm saying the real fact. So we are hesitating. As a dentist, we are not doing general things. So if at all patient is diabetic, we are there to just pull out the tooth. But we should check the diabetic level. We should check BP. How many of us check BP before doing extraction? Almost 60% of our cases, we are not doing it. Only 40 to 30%, somewhat rarely 30% of patients only I am seeing BP. For 60 to 70% of people, I am not seeing BP, but check BP. Because all of a sudden, randomly, if you check BP for some patients, 200, 120, everything will be there. Sudden stroke is possible, high bleeding is possible, cardiac arrest can be possible. So everything can be possible, but check it and record it in the case sheet. Even if it is low, it's quite good. We can write it in the case sheet that BP was this value prior. So it will be documented and sure no medical legal issues will come if you check BP saturation, because after COVID era, saturation of this pulse oximeter is a part of the clinical dentistry. So we should have all these equipments, random blood sugar, HbA1c, whatever sugar levels you should see. Liver function test and renal function test is prime important. Why? Because I have seen lot of cases. 2 days before also I had a case. He said, after taking 2 RCTs, he continued with me. After 2 RCTs, I have given him antibiotic for 5 days. For 5 days antibiotic. Following that, after 5 days, he had a fever. After fever, he got admitted. After 10 days of my procedure, he got admitted in hospital. And his age is around 80, 82. That person is having some 1.5 or 2 creatinine level. The doctor said that he is having high creatinine level. That is because of this painkiller. He called me and informed me that my kidney problem arises because of this tablets. I told him clearly, no, not because of it. I have given you just for 3 to 5 days. Long term, as if you say 3 months to 4 months, if you take, it will happen. For general, in general, it will happen, not in 3 to 5 days conditions. Already you are having some aggravating factors. So if I could have seen his RFT prior to dental extraction, I can notice him and I can say them that you are having some renal issues, so don't try to take these medications too long. Cut short it and go and meet your dental medicine people. So I could have escaped from that issue. I didn't do. So taking LFT, liver function test and renal function test is not at all a crime as a dentist. And serum electrolytes will give you a plenty of details. If all your serum electrolytes level is a normal parameter, no syncope will be there for the patients. If at all some alterations is there, some reduced level, some increased potassium level, everything is there, there is chances of syncope or anything else will be there. So check all these basic vital signs. I am not saying all blood investigation. If you are having any doubts, you can opt for more blood investigations also. There is no crime that we cannot make any blood initiation. We should not do any blood initiation. Make use of this blood initiation, and this blood initiation is not too costly. It is very cheap, so we can make use of it. Lot of liver disorders. Coming to the liver disorders, cirrhosis of liver is most commonly seen nowadays for even in young people, because of their food habits, because of alcoholism, and because of this thing. So cirrhosis, if at all patients report to you, there will be low chances of coagulation factors. There will be bleeding disorders sure for the patient. So we should measure the LFT value. We should seek your opinion. Then we have to touch the case. And NSAID should be avoided for hepatotoxic as it is hepatotoxic. And paracetamol is the safest drug, and it can be given up to 2 grams also. And in advanced cirrhosis, tramadol should be avoided as it is metabolized in the liver. And the hemostatic agents should be applied post-operatively as a prophylactic method. Because after socket extraction, you can fill the socket with some hemostatic agent and pinch it so that post-operative bleeding won't occur. And coming to renal disease, impaired drug excretion will be there for the patient. So avoid NSAIDs for those patients. And if at all patient is having renal problem, there will be platelet dysfunction for the patient. And if at all patient is under dialysis, we can't able to say them that I can't able to do the extraction for the patient. Even for a dialysis patient, we can do extraction, because before the day before dialysis, they will stop their heparin and they will go for dialysis. For the patient, either on the day of dialysis, if the patient is having normal BP, we can do extraction. Otherwise, the very next day of dialysis, we can go for extraction. And if transplant is done for the patient, kidney transplant has been done, within 3 months or 4 months of time period, the procedure should not be done. And if he is under immunosuppression, proper antibiotic coverage should be given for the patient, and we can do the procedure after seeking medical opinion. And clindamycin, metro, azithromycin are safe drugs for this macrolide azithromycin is safe for renal problem patients. And these patients, paracetamol is quite safe. Tramadol is also safe. And always more prone patients, HIV patients, is there for dialysis. Post-operatively dialysis, because of the dialysis unit or something, lot of patients occurred HIV. It was, I heard, but I didn't have any documentation on it. So HIV and hepatitis is most common. If the patient is going for dialysis, you just follow all these things, check all these things, and then you proceed for it. In pregnancy patient, always gestational diabetes is more common in patients. Control diabetes and then do extractions. First trimester, as you used to say, first trimester, avoid procedures. But in case of emergency, we can do procedures. No issues in it. Drugs should be given in a limited manner. And emergency procedures in the second and third procedures can be done. Avoid radiographs. Supine position should not be given, as it will compress the vena cava. And right hip elevated 10 to 12 centimeters is the right position. And full lateral position cannot be kept for a long time. And coming to CVS, hypertensives are more risk for thrombotic events. As I said, monitor BP priorly. Because one thing I have seen, seeing BP with the BP apparatus will give trust in you, particularly in elderly individual. If you touch their hands and see BP, your trust will grow like anything. So during extraction, they will confidently sit in front of you and they will do it. So anyway, we are going to charge for extraction. So see BP, see vitals, and then you do procedure. If at all you are having high BP, postpone the procedure. Always early morning appointment or midday appointment is quite safe for BP patient. Midday appointment should not be given. Early morning appointment is safe for patients. Anxiolytics should be given day before procedure. Anxiolytics means injection diazepam or tablet diazepam. Orally can be given to reduce anxiety, to reduce stress level at the time of extraction. For a malignant hypertensive patient, I am saying, not for regular hypertensive patients. And morning appointments, long-term NSAIDs should be avoided. Why? Because our NSAID, aceclofenac, diclofenac, will have interaction with hypertensive drugs, antihypertensive drugs. So drug interaction will be there. So we should avoid all those things. And anti-thrombotic agents. How to deal with these patients? antiplatelet drugs, that is aspirin or anything else, will give prevents platelet aggregation. So aspirin, clopidogrel, all these comes under this antiplatelet drugs. So anticoagulants should be stopped 2 days or 3 days before procedure. Only thing is, anticoagulant should be stopped 2 or 3 days before procedure based on how many years the patient are taking anticoagulants. If at all the patient is taking anticoagulant for more than 2 years or 3 years, and the patient is under double therapy, that is aspirin and propylate altogether, then you have to check the INR value, then only you have to do the procedure. If the patient is taking short-term aspirin, you check, stop the drug, and you can do procedures. Heparin is a low molecular weight heparin. Then all these drugs, warfarin, heparin, enoxaparin, no need to stop these drugs at the time of procedure. Why? Because it won't interfere in platelet aggregation. The pathway is different. So even in heparin, enoxaparin, and warfarin patients, we can do procedures. Proceedingly, we have to carefully handle the soft tissues because mild wounds can be there sometimes. Suturing can also be done if needed. And double antiplatelet drugs, that is aspirin and clopidogrel, will be given only for recent MI patients or recent CABG patients or patients under stent. So if at all the patient is taking 2 drugs altogether, then you have to monitor all these parameters, then you have to do. Preferably, you can take a cardiologic opinion for stopping the drugs if they are taking double therapy. Otherwise, you can stop off our own and we can do the procedure. Manage with hemostatic agent. Lot of hemostatic agents are there. The control bleeding and low hemorrhagic procedure should be done. If at all you are assessing that it is a high bleeding procedure, you have to opt for GA or some other treatment options because ligation and the control of bleeding will be better in GA than compared to local anesthesia. And always get opinion if you are having doubts. Based on the scale, if you experience and won't send for opinion for these many cases. Beginners will have some doubts. If you are having doubt, don't hesitate. Keep in touch with the doctor. You send them, they get an opinion and do it. There is no harm, there is no wrong, there is no ego in it. And coming to local anesthesia, which is prime important for us for all minor surgical procedures. So good LA technique, first of all. Particularly for all maxillary tooth extraction or any maxillary procedures, there is no technique. Only technique in maxillary region is infraorbital no block, and all others are just an infiltration theoretically, clinically, but it is said to be theoretically called as block because of the cancerous nature of the bone. But for all mandibular tooth procedures, we have to go in for a inferior alveolar block, which is a technique sensitive block. We have to go in an apt landmark, feel the finger, oblique its retraction, occlusal surface of the tooth, height of the injection will determine the occlusal surface of the tooth, meet that height, hit the bone, aspirate, and then deposit. So good technique is prime important on achieving a good anesthesia. Good volume of anesthesia should be given for inferior alveolar block. Unlike other block, we can't able to give 1 ml or 1.5 ml. 2 ml is adequate for inferior alveolar block. We can give it and always aspirate before you deposit. Why? Because without aspiration, sometimes if it is inside the blood vessel, if you are injecting it, sudden palpitation will be there for the patient, which will increase the anxiety level of the patient. If the anxiety level of the patient is increased, some systemic complication, even if there is no complication, some complication can arise. So always try to reduce the anxiety to the patient. If you want to reduce the anxiety to the procedure, my sirs usually used to say, split the dental procedure. Don't try to do it in a single sitting, particularly in surgical care. Why? Because you can give a good denture for the patient in a single day. You can load implant with the crown in a single day. But surgical procedures are not like that. We don't know how the patient reacts to any surgical procedure. So my experience with the surgical procedure is, even if I know a quadrant extraction or a total extraction, I will avoid all those extractions in a single sitting. Why? Because let the patient come to us in a multiple sitting. If there is no other chance, patient is having going here and there is no way to meet you, there is no chances, then we can proceed it. But all other circumstances, you kindly do a split technique. Split the procedures, which will reduce the anxiety level of the patient. And another important thing in local anesthesia is slow deposition of local anesthesia. Always, even if he's having some root cause, even if he's having some systemic issues, if you fastly deposit, it will aggravate the issue. So slowly deposit, nothing will happen to the patient. And precaution should be given in PSA nerve block. Don't insert the needle too deep in the posterior surface of the maxilla. Pterygoid plexus is there, hematoma will be there. Lot of my students, even my friends used to call me and they'll say, after injection, sudden swellings there in the cheek. That is only because of the pterygoid plexus. So don't go too high. So only 1/3 of the needle should enter in the posterior region, just deposit and come out. That is more than enough. And more than 2 to 3 cartridges is needed for an elderly patient. Don't overload for these patients because either we can withdraw the procedure or we can partially complete the procedure and we can come out. But overloading of NLA will cause some systemic ill effects. If you want to discuss about local anesthesia complications, this is another thing we will meet if possible in the future. So local anesthesia, you should not rush it, you should not rapidly fill it, and volume loading should not be done for it. Avoid vasoconstrictors. This is not a quite good concept, but avoiding vasoconstrictors in the peripheral areas is quite good. But for hypertensive patient, even for malignant hypertensive, vasoconstrictor is quite safe drug. Why? Because absorption of the drug, absorption of local anesthesia won't be there if you give along with vasoconstrictor adrenaline. Without vasoconstrictor, something can happen to the patient, so you don't need to avoid vasoconstrictor. Vasoconstrictor can be given for the patient. This is the recent article says, give LA with vasoconstrictor, no plain LA for the patients. Only for one condition, we should avoid vasoconstrictor. That is for hyperthyroidic patient. The condition is called as thyroid storm. Thyroid storm is nothing but if you inject with adrenaline, palpitation will be increased for the patient. So sudden palpitation will increase heart rate to the patient. So this will cause some ill effects to the patient. So avoid vasoconstrictor for hyperthyroidic, not hypothyroidic patients. And coming to diabetic, as you all know, most commonly encountered patients in our dental practice, a lot of death throughout the globally happens because of diabetes only. All these because of increased susceptibility to infection and delayed healing. More prone, diabetic patients are more prone for infections. Practically, I have seen a lot of cases because of this diabetic issues, and they are more prone for infections. And now South Indian populations, they are gaining more diabetic indexes. Patients are increasing day by day. So have a good infection control, keep our instruments safe before doing the procedure, and plan accordingly. Ask them how many years they are having diabetic. All diabetic patients are not susceptible for infection. Patients, long-term diabetic patient associated with some other systemic diseases, associated with some other immunocompromised conditions, associated with some other steroids injections, it will pave way for infection. So not only diabetic, it is a chart where we should see all the other parameters. So all these should be kept in mind before starting the procedure for the diabetic patient. You question the patient for how many years you are having diabetic, what are all the symptoms you are having, whether you are having a good renal issues, whether they are having pitting edema or not. As I said in the first slide, head to toe examination, neuropathy, retinopathy, nephropathy, all these are diabetic indexes. Peripheral numbness will say that the patient is having long-term diabetics. Visual disturbances is there if the patient is saying retinopathy, long-term diabetic complications. Nephropathy, that is renal issues is there. These patients are prone for chronic renal diseases. So your target value should be 6.5% HbA1c, less than 250 milligram, which is said to be called as the renal threshold level. More than that, if you give, the kidney won't function properly. Your drugs won't excrete properly. You can't able to give painkillers to the patient. So all these should be kept in mind. So for a diabetic patient, we all know about it, but carefully handle about those things. And where there will be a doubt regarding insulin dependent patient. Patient is taking insulin, no issues. Insulin dependent patients are safest patient. Only thing is whether they have taken food or not. When they have taken the last dose of insulin, that is prime important. After, if you ask these questions, you can do the procedure because they are more prone for hypoglycemia. But if they have taken their meals, immediately after their meals, if you are doing extraction, nothing will happen for the patient. And as usual, morning appointments is the right time to do extraction after their breakfast. Assess glycemic level, refer patients with signs and symptoms. As I said earlier, if their patient is having long-term diabetes and they are having those signs and symptoms, if they are if you have arise a doubt that they are having some renal issues, just refer the patient. That is important. After getting opinion, after receiving their blood report values, then you can proceed the procedures. So aggressively treat acute oral infections. Why? Because two schools of thoughts is there. If the dental infection is high, particularly in dental cases, and blood sugar level is also high, what we should do, whether we can do extraction or not. First, if at all infection is there, draining of the infection is prime important. There no need to worry about this high blood sugar values. Why? Because this infection will also indirectly increase the blood sugar. If you reduce infection, the blood sugar level will also get reduced. That is one school of thought. For an elective procedure, if at all blood sugar level is very low, then you proceed. If it is below 250, you can proceed. If it is 400 and the patient is having acute submandibular space infection, we can't able to ask the patient to wait to reduce the diabetic and then only have to report to us. We have to immediately drain the abscess, then we have to proceed the other thing, and you have to seek the opinion, medical opinion. If those patients reports to you, kindly admit the patient and do for your safe hands. And respiratory diseases, lots and lots of respiratory diseases are coming to the patients. Shortness of breath is there, fibrotic lungs are there. Even after COVID, lot of patients report to us, lot of patients is having asthmatic. All those patients are not a contraindicated patients. They are not absolute contraindicated patients. Certain precautions should be taken. Inhalers, whether they are using, ask the inhaler to bring along with them. Don't keep the patient for upright position for so many hours. Why? Because diaphragm compression will be there. So keep them in semi-supine position. Short procedures, as I said earlier, minimize the procedure. As soon as possible, you send the patient out. Avoid NSAIDs. Even a single tablet of aceclofenac or diclofenac will cause bronchospasm. So plain paracetamol can be given, tramadol can be given, but this aceclofenac, diclofenac should not be given for asthmatic patients. And these are all some of the emergency drugs we should keep in our dental practice. We are authorized enough to handle all these drugs because we have read our pharmacology. As we are not using it regularly, we are not updated to these drugs. But my sincere thing is, keep this aside in a clinic. I am having a box separately and all these medical emergency drugs are there. Check expiry date every 6 months once and change the drugs and keep it there. Keep on oxygen. I'll show you the next. Sublingual nitrate, which is highly useful for chest pain. It is a vasodilator and dispersible aspirin tablet for sudden chest pain patients. You should give salbutamol inhalers for asthmatic patients. Adrenaline injection in case of anaphylactic shock or some local anesthetic shock, we can give adrenaline. Glucometer is an essential thing for a dental practice. Oral glucose solution, glucogen injection for acute hypoglycemic patient. If you give glucogen injection, immediately the patient will come out of hypoglycemia. Midazolam in case of anxiety, in case of epilepsy, we can give this midazolam. No harm in it, no side effects in it. We can give intravenously also. If you are worried about things, you can give intramuscularly also. O2 cylinder. How many of us are having O2 cylinder in our practice? It is not expensive. We are spending money for scanners. We are sending money for CAD cam. We are having lots of expensive instruments in our dental practice. But all surgical instruments are one-time invested instruments. If you bought a forceps, I am having my forceps for 23 years, more than 23 years. Periostral letter, I am having it for more than 20 years. So all these are cheaper instruments. All these drugs are cheaper drugs. So try to keep it in near dental practice, because in case of emergency, even if you are not going to do these emergency procedures, some emergency person is coming to your clinic, they can handle it. So they can take this drug and they can give it. Even a patient attender can be a doctor. So they can able to save the patient. So don't try to hesitate to buy all this. A simple B-type O2 cylinder is a small cylinder which costs around 5,000 or 4,000 or 7,000 initially. Once you keep it inside, each and every time if you refill it, it costs around 500 or 600 only. O2 oropharyngeal airways. Oropharyngeal airways, I will show you. O2 face mask is important. Ambu bag is important for positive air ventilation. And how many of us know about this airway? This is called as Goodell's airway. This Goodell's airway is said to be called as plastic airway, which is 150 rupees in your online market. If you see, which gives you 6 to 7 colors, they will give 6 to 7 pieces they will give in different sizes. One packet costs around 150. In case of sudden fallback of tongue, in case of sudden syncope, in case of upper respiratory blockage after giving LA, some hematoma can also obstruct the posterior airway. After giving LA, anaphylactic shock can happen. Because of that, lingual edema will happen, which will cause upper airway obstruction. To immediately secure the patient's airway, intubation is not possible from our side. So you can keep this Goodell's airway. By in an inverted fashion, you have to get it to the palate, and if you rotate it, it will go beside the tongue. So we can give a good ventilation over there. And this is another oropharyngeal airway. We can keep it inside the tongue, posterior to the tongue, this blue colored one. This is also airway. So all these oropharyngeal airways will be handled by the patient. You can see this in this picture. In this manner, you have to insert it. Once if you insert it, and once it goes gone inside, you have to rotate it downward. So this green arm will come downward. So the airway will be like this later. So your pre-operative assessment, clinical assessment, diagnosis, radiographic diagnosis, airways, your medically compromised patient, when to take up the patient, when not to take up the patient, everything will be clearly known to you after seeing diabetes, hypertension, blood transfusion, everything. After that, you have to prepare the patient. Preparing the patient preparation is nothing but keeping a good armamentarium. Keeping good armamentarium is nothing but keep all the surgical items and then you start doing the procedure. And nowadays, for all general dentists, CPR training is mandatory. So you have to go for CPR training. Any official centers, lots and lots of courses are there. Authorized courses are there. They will give you a CPR trained person. Like that, they'll give you a card. So try to complete the CPR courses so that you know about all these emergency kits and everything. You all know about this thing. Anyway, for my completion purpose, I am saying it. And consent, why I am stressing on consent is medico-legal issues. As I am working in our college is now changed into government college. Because of that, lot of opinion cases used to come there. Lots and lots of medical legal cases, private cases or whatever cases done outside, they are asking for opinion. What to do, what happened, whether the patient has been treated properly or not, like that. So if at all consent is there, we are safe. If consent is not there, we are not safe. So try to ask consent. To get consent, 2 things are there. 2 types of consents is readily available in the net. Our idea is giving some consent format. You can get signed from that consent format. Or our AOMC is giving some format for general surgery, general anesthesia procedure and local anesthesia procedure. So those consents should be obtained before doing the procedure. So preparation based on armamentarium and consent. Once you got all these things, then you have to proceed for intraoperative thing. At the time of intraoperation, some syncope occurs. How to do? Alert the patient, give verbal commands, remove foreign bodies, ask the patient to raise their leg or lift the leg. Don't try to feed anything. At the time of syncope, don't try to give any glucose powder or liquid to the patient, which will give you aspiration pneumonia or obstruction, further obstruction to the airway. Monitor pulse, and if the pulse is tachycardic and then slowly it is reducing, it is said to be a normal syndrome. Seek support. If the patient doesn't wake up, the patient is going in for deep syncope. If deep syncope is there, shift the patient and seek medical opinion. Otherwise, 95% of syncope patient will come out from normal way. And what is hypoglycemic syncope? Hypoglycemic syncope, from the beginning itself, the patient will have bradycardia, that is, reduced pulse rate will be there, no response will be there, excessive sweating from the body will be there. How to manage it? Monitor immediately the blood glucose level. Coming to regular syncope or hypoglycemic syncope, monitor blood glucose. As I said, glucometer is essential in our practice. IV glucogen injection, that is 25% dextrose or 50% dextrose in a vial is there. Break that vial, as load it in a syringe, 10 ml syringe, intravenously is just rush it. The patient will come out of hypoglycemia, sure. No need for hospitalization. If you are having doubts, hospitalize the patient if needed. And coming to anaphylaxis shock, which is unavoidable condition in a dental practice, which is very rarely used to occur, and we doesn't know what happens, how to manage, what is the outcome of it. Even anything can happen, but anyway, we are ready enough to handle this issue. Anaphylactic shock is nothing but a drug allergy. It can happen after a penicillin injection. It can happen after a local anesthetic injection. It can happen after a diclofenac injection. So fallen BP will be there. The respiratory disease, distress will be there. All smooth muscle secretions will be increased because of that edema. Laryngeal edema will be there, and cardiac function will get slowly reduced. The patient will go in for life-threatening conditions. So the management for anaphylactic shock is first reduce the edema. So antihistamine management. After giving antihistamine, as I said earlier, airway should be given. After giving airway, if you are confirmed with this allergy condition, don't hesitate to give adrenaline. Adrenaline should be given 0.5 cc subcutaneously. In an insulin syringe, you have to load it and you have to give it in a subcutaneous, intramuscular, not muscularly, too deep also. It should be given subcutaneous, like insulin injection, you have to give in a frequent interval. How much interval you have to give it? You have to give it in 5 minutes, every 5 minutes interval, you have to give it. And hospitalization and monitoring is quite important for anaphylaxis. Basic thing is airway, Goodell's airway should be placed in the oral cavity, antihistamine, adrenaline injection, and shifting the patient to casualty is very important in anaphylaxis. And coming to exodontia, for a regular extraction, dental extraction, as I said, anti-anxiety protocols, that is painless injection to the patient. Speak with the patient before doing the procedure, then start doing the procedure. If you speak with the patient and then while speaking, if you remove the tooth, they will be so happy and they will say outside also, your patient will also get multiplied. They will simply come and say, Dr. Pesite has removed the tooth, like that they used to say. So speak with the patient, reduce their anxiety. Soft tissue handling is quite important. Even if you got fractured, tooth is fractured, there is no harm in it. If the path of exit is not proper, the tooth will fracture. It is not a crime. Once that is get fractured, raise the flap, go deeply engage the forces, try to do it in alveolar purchase manner. If it is not possible, shift the patient to other table, make ready with the armamentarium, cut the bone, remove it and do it. It's quite easy and safe. There won't be bleeding at all. If you damage the soft tissues, sure there will be bleeding and other associated complications. And one more thing, 2-3 cases I have encountered in the last 3 years. If you are removing your third molars while attempting it, the tooth is not coming out. It is well said that the path of exit is not there. If path of exit is not there, what is the purpose of pushing the tooth furthermore? If you do it more, what happens? Angle fracture, some brittle bone will easily get fractured, some amount of complication will arise. So we can avoid this complication. If path of exit is not there, inform the patient that the root is curved. I have to cut the bone and then we have to take the root. That is the only possible way. If the patient accepts, you do it. Or priorly before procedure, you just inform the patient, I'm going to do a normal extraction. If at all the tooth is not coming out, I have to opt for open method. If you are willing, I will start the procedure and then we will start the procedure. And for proper positioning is important. These two important positions. This is semi-supine position for all maxillary tooth extraction, and this is upright position for all mandibular tooth extraction. And hemostat is very, 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 very important. Achieving hemostat is prime important. If at all bleeding is there, don't try to control the bleeding. Don't try to keep a cotton over there and send the patient out. Don't have a motto by sending the patient out alone. You have to control the bleeding, then only you have to go for suture. That's why I have given the slide, hemostat first, then only sutures. So if you didn't achieve hemostasis, bleeding is there. If you put sutures, blood will escape from the soft tissue and go to the dead spaces. So hematoma will be there more for the patient. So try to control bleeding, then we have to go. As I first said, for doing a good surgical procedure, gaining access is very, 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 very important. How to gain access from the patient? This is the way of putting incision. If you are going to place any incision, front to back stroke. You have to start from the front and then you have to go back. That is the only stroke of VP handle. You should not go from back to front stroke because that is not a controlled stroke. Front to back is the controlled stroke, and avoid nearby anatomical structures while placing incision. Whatever the approach you are going to do before itself, whether it is a clavicular incision, whether it is a symphonar incision, whether it is a simple vestibular incision, priorly you decide it, avoid all anatomical structures, then start doing. Always flat design should be, the base should be broader and tip should be shorter. Why? Because increased blood flow will be there, tip necrosis won't happen. So it should not be like this, it should be like this. And hemostat for achieving human fat, pressure pack. If at all bleeding is there, retained extracted tooth inside the socket, placing hemostatic agent and suturing. These are all lot of hemostatic agent. Abgel is more friendly use. Abgel, we can use it more friendly than any other thing. And some powders are there, liquids are there, lot of hemostatic agents are there, collagen plugs are there. So you can place it in the extracting socket to achieve hemostasis. And these are all some of the suturing principles. Hold it in a 3/3 and equidistance you should place suture. Perpendicular to the suture incision you should go, as you all know. And these are all the general principles and some tricks about minor oral surgery. I don't know I have fully covered or not, but as a simple thing has reached you, I think so. And now I'll go in for some case, minor surgical cases. I'll show you some of my cases. I don't know whether it is minor or major, but in the institutional purpose, I have seen a pathology in the cheek mucosa, this much huge pathology. I asked the patient, and on seeing it, I have thought that is a hematogenous origin. So blood vessel related tumor or not, I don't know. So we have opted the patient for investigations. He has made the investigation and they have concluded that there is no hematogenous origin. That is, there is no blood flow into the lesion. Then I have pricked with the needle, there is no blood flow. You can see the prick over there. So there is no pumping blood. If at all it is hemangioma, bleeding will be profuse. So then I concluded, then started doing my minor surgery. Simply I exposed it and I have removed the end toto. While removing this thing, you can see the branch of facial artery over there. So then I noticed it. If I didn't see a blunt dissection, if I did, profuse bleeding will be there. Only one artery is feeding the lesion. So we can remove the lesion, we can clamp it and we can suture it. This is ideal, not the ideal case for local anesthesia, but it is not too ideal for general anesthesia also, because It hardly took 15 minutes to remove the thing. The thing to learn from this case is, before doing the procedure, what content it is having, whether it is aspiration, whether fluid is there or not, whether any blood vessel is there or not, or any blood flow is there or not. If you rule out all these things, then you can opt for minor valve surgery. And this is also another important case. I don't know, this patient is having some swelling in the extraoral. I'm not having clear pictures of it. So the swelling was fluctuant and soft in consistency. The patient is simply saying he has a history of trauma before 10 years. At the time of trauma, he had made some sutures inside it, and it was a roadside accident, and he said some foreign bodies might be there. Following after 10 years, he is having some swelling over there. I opened it. This case also I ruled out whether bleeding is there or not, blood vessel is there. After ruling out all the parameters, all the health parameters, all the systemic conditions of the patient, then I have opened it up. Once immediately opening it, greasy-like material came out. It says some keratogenic material or something. Because of pre-operative surgical procedure, it happened like that. It is a very rare lesion. This was done under local anesthesia. And these dilemmas, whether infected canine should be done palatal approach or buccal approach, all these will be clearly read in CBCT. So if at all canine, this thing is there, no need for shift bone technique or holder technique. Take a CBCT, confirm it whether it is in the palate or in the buccal side. Then clearly if it is in the palate, I have made investigation, this patient is having palatal placed root tooth. The crown is there in the palate. So I have made a palatal approach, raised the simple flap, and I have removed it. So this decision making arrives at a good radiograph. For that purpose, I said. So, okay. On seeing all the wider, bigger lesions, it is not said to be GA. This type of simple lesion, just a cut injury, the patients reported to me. I have made a wiring. After made dental fracture, I have placed IMF. After placing IMF, I have closed the lip under local anesthesia. Simple lower lip, particularly in lower lip anterior region, access will be good for us. Just a mental no block will give you adequate anesthesia to the patient also. Pain will be very minimal for the patient. So these are all the points which we should clearly assess and we should take up for local anesthesia. On seeing it blunderly, we should not say, because as the patient is young adult, we should not subject him for general anesthesia. Instead, we can do it under local. And this type of small cyst, we can do under local anesthesia. And if it is too huge and it is communicating with the sinus and if it is going too posteriorly, opt for general anesthesia. No need for local anesthesia. If it is in your accessible area, opt for local anesthesia. Like this upper anterior or any lower anterior, small cyst can be done under local anesthesia. And this was a good case referred from me by my professor from Kumbakonam. I don't know what type of lesion it is, but after seeing the lesion, it was a small lesion. I just thought it is a varicose carcinoma variant, verrucous carcinoma. So verrucous carcinoma, sometimes nodal spread will be very minimal. So I thought I'll go for local resection. So considering the age of the patient, and patient is also not willing and not affordable for general anesthesia, I have opted this patient after this evaluating systemic conditions. I have removed the portion of CA and send it for biopsy. Post biopsy said verrucous carcinoma, but nodal metastasis was not there. But I can't able to say what will happen to the patient. But anyway, primary lesion has been removed, and it was more than 3-4 years. I am having follow up with the patient. Nothing, no spread was there for the patient. He is healthy now. And coming to impaction, as I said in the beginning, cheek laxity, measuring cheek laxity is very important. After that, oblique visualization. Once oblique visualization, this is another important thing I can take in some other lecture. Impaction, when to do crown section, when not to do crown section. based on the arc of rotation, based on the amber line, red line, everything you have to mark it. We will take it in the next lecture sometimes. And to conclude my lecture, proper diagnosis, preoperative assessments, preoperative preparations will pave way for a smooth and comfortable surgery with or without minimal complications. Thank you for your valuable time sharing with me for this 1 hour. And thank you so much for all your active participation. Thanks the team Vriksha for giving me this chance. And thank you, one and all. Thank you so much. Any doubts
Thank you,
you
sir.
can ask.
A very informative session by you, sir. Thank you so much. And especially your cases that you showed at the end really helped us to plan. And participants, if any doubts are there, you can start asking. You can just unmute yourself and ask questions or doubts if you have.
And hope the
So we are receiving few messages just thanking you for the clinical tips. And any doubts regarding the session? You can unmute yourself and ask. Don't hesitate.